Hi guys, welcome back. The next topic that I'm teaching you is Syringomelia, which would basically mean dilatation of the central canal of the spinal cord. Now, most of the time when this central canal will expand, it will press on the lateral spinothalamic pathway, which carries pain and temperature. Because these sensations would be lost mainly in the hands of the patient. Therefore, one of the very characteristic statements in this particular case would be painless burn in the hand. Like this person could be actually making a coffee or tea for himself and the hand of this person accidentally touched the hot plate. But in spite of getting a first degree burn or a second degree superficial burn, this person will not be able to perceive the pain component associated with the burn. So that is why I made this very characteristic statement. Now I will explain to you that how this disease will evolve. So in case you're taking notes at the moment, please do not draw because I'll modify this diagram. What I'm highlighting in this case is the central canal, which will be having the CSF. Posteriorly, I have shown the dorsal column, which is responsible for carrying proprioception, that is joint and position sense. You see, if I ask you that can you feel your ankle joint, you don't need to look down to see the position of your ankle joint. You can just perceive your ankle joint position, knee joints position, the way you're sitting on a chair, the position of your legs per se, with help of the dorsal column that I've highlighted. What I'm shading at the moment is the lateral spinothalamic pathway, and this is the one that is usually impacted in this condition primarily. Why? Because it is just adjacent to the central canal. The lateral spinothalamic pathway carries two sensations, that is pain and temperature. Both of these would be hampered as the syrinx, that is the dilatation of the central canal, will expand asymmetrically. I have now highlighted the ventral spinothalamic pathway, which has been shown towards the anterior aspect. Well, the sensation that is carried by the ventral spinothalamic pathway is crude touch and pressure. Let us just quickly remember the facts that I have just said at the moment. I've talked about dorsal column posteriorly for proprioception, lateral spinothalamic for pain and temperature, and ventral spinothalamic tract, which is mainly responsible for carrying crude touch. Now, once you get this orientation right, I'll slightly modify the diagram. I want to highlight that when it comes to the lateral spinothalamic pathway that I'm zooming in at the moment, then the fibers which are carrying the information into the cervical part of the spinal cord versus the fibers from the thoracic versus the lumbar versus the sacral are arranged in the fashion that I've shown here, that the cervical fibers are present most medially and the sacral fibers are present relatively laterally. Let me make this representation of the contralateral side also. The cervical fibers are present medially, then would be thoracic, lumbar and the sacral fibers. Now the importance of knowing this information is that when the syrinx will expand, this is the central canal, this is where the CSF of the patient would be present, and as the central canal will expand, it will first impinge on the cervical part of the lateral spinothalamic pathway, and because the cervical fibers are impacted first, that is why the sensation in the arms would be affected first, sensation in the hands would be affected first, and this also explains why I showed you this particular diagram where he's highlighting the loss of sensation, especially in the arms of the patient and in the hands of the patient. In fact, the term that is used to describe this is called as a cape distribution. What I mean by cape distribution is if you see Superman's character or Spider-Man's character, they're always having a cloth around them, no? So the cloth would be covering over the shoulder, or like in India, I can say in winter season, a woman would be taking a shawl. Right, so cape distribution basically means covering the shoulders and the arms of the individual, and that's mainly because the cervical fibers are involved first. Let us now see how the syrinx will develop in this case. This is a developmental malformation, guys, actually, and that is why I was initially asking you not to draw it so that I can modulate the diagram now. I have now shown the central canal expanding asymmetrically. You can definitely notice that in this case, not the entire spinothalamic pathway is affected even medially, because if there's going to be a direct impact in one particular area, I have still shown an area that may be unimpacted at the moment, but as the syrinx will progressively increase, that is when the cervical area can be involved, and then whole of the shoulder distribution, arm distribution, forearm distribution, hand distribution would be having a loss of pain and temperature. I want to highlight this again, guys. Initially there might be a patchy loss of pain and temperature, then it might become bilaterally symmetrical. So don't be under impression from the diagram that I just showed you that it's going to be bilaterally symmetrical manifestation. The syrinx expands asymmetrically, so you may or you may not have a bilaterally symmetrical presentation. On this, the usual query of most students as well as the examiner will be, why is it happening? Doesn't happen in you and me. You will answer here a congenital malformation, though the causes can vary even from trauma onwards. But one of the important causes that the examiner loves to hear here is called as Arnold-Chiari malformation type 1. In fact, guys, there are 4 types of Arnold-Chiari malformation that I'll subsequently explain to you in this particular lecture itself. At the moment, I want you to remember Arnold-Chiari malformation type 1 is not a neurative defect, not a neurative defect. It is present since birth, but the manifestations will develop in adult age group. I want to draw parallels here. Like I taught you, atrial septal defect could be present since pediatric. In fact, since birth, it has a pediatric onset, but the manifestations develop in adult age group. AST becomes symptomatic and usually lots of time adult age group, sometimes even diagnosed at the time of pregnancy. Similarly here, I want to draw parallels that Arnold-Chiari malformation is present right on day 1. As the syrinx will progressively expand, the manifestations will be perceived by the person when he goes into adult age group. The cape distribution and the word painless burn in the hand is a very characteristic manifestation that will develop in this condition. So let us now work up the clinical features that would be written in the question. In fact, most of the important ones I have already highlighted, but there are still some that we have to learn. You see, when you read this question, painless burn in the hand, it is straightforward a diagnosis of syringomelia because you don't read about this terminology anywhere else. Apart from this, because pain is a feature that brings a patient to a doctor. You see, if you and me get injured on our palm because it will hurt, what are we gonna do? We're gonna put antiseptic cream, we'll put up a bandage, we'll try or avoid putting this hand in water. I want the injury to heal so that I can use my hand once again. But in this case, because there's no pain perception, person will neglect the injury. There might be another injury over the same injury, like he got a burn on his finger. You see, I'll put it like this. This particular individual, till let me say 17, 18 years of age, he was in house and his mother was doing all the cooking. But he got admission into a medical college, let me say, and he has gone to a hostel. And now in the hostel, he has to fend for himself. He has to cook for himself. He's cooking Maggie for himself at night. His hand has accidentally touched the hot plate. Though he got a finger burn, he is not going to perceive the pain. Initially, he might neglect it. There's a possibility that he might get burnt a second time over the initial burn. Imagine, burns are always painful. Imagine a second burn developing over the same pain, over the same injury because it does not hurt. And then subsequently, there's a possibility that there might be a development of what I'm highlighting now, that is a non-healing ulcer in the hand. If I was describing non-healing ulcer in the sole of the foot, definitely we would have thought in terms of or a possibility of diabetes mellitus, but non-healing ulcer in the hand is very characteristic for syringomelia. And the reason I explained why in syringomelia arms are involved first is because of the anatomical arrangement of fibers. The cervical fibers are present most medially and the sacral fibers are present relatively more laterally. Subsequently, the non-healing ulcer can get infected also. This could contribute to destruction of the small joints of the hand, and therefore the manifestation developing in this chap would be Charcot joints. In fact, meaning of the word Charcot joints would be painless paralyzed joints. When you read this terminology, painless paralyzed joints, Charcot joints, the number one cause I've already told you, that is diabetes mellitus. But over and above diabetes mellitus, I want you to remember even Taves dorsalis and the current topic that we are studying, that is syringomelia. In fact, when it comes to diabetes mellitus, it is the small joints of the foot. I repeat the fact once again, it is the small joints of the foot that are involved in diabetes mellitus, which can cause foot deformities. But when it comes to Taves dorsalis, it is most of the time the ankle that is involved, and then syringomelia, it is the hand that is involved. When it comes to sensory deficit in these patients, when you do a sensory examination of this individual, you will notice a very characteristic manifestation developing due to the asymmetric nature of the disease. There might be a patchy loss of pain and temperature. When you're doing a thermal examination of this patient and checking for pain and temperature loss, you might notice on left and right, it's not going to be the same. I want to highlight that in this case, this deficit of pain and temperature tends to progress from proximal to distal. That is, the sensory deficit would be first over the shoulder and the arms and then will progress to involve the hand. You see, if you cannot feel hot, cold, thermal sensation over your shoulders, it's not gonna matter. The person will not even be aware of the fact that he cannot perceive hot and cold over the shoulder. It is only when you are cooking and the hand touches the hot pad that there could be a burn, and he's neglecting that injury per se because it really does not hurt. It is only in the later part of the illness that the index finger or the hands of this person will get involved. So I have just increased the deficit now to highlight that the MCQ deliberately could actually mention distal to proximal progression. This is a proximal to a distal progression of the sensory deficit that is developing in this case. From the fourth point, I wanted to highlight the asymmetrical nature. It's an asymmetrical patchy deficit or patchy loss of two sensations, and that is again a term that you need to remember, that normally when you are having a deficit in the spinal cord at a particular area, only one sensation is gone. Here two sensations together, pain and temperature, are lost simultaneously, and then subsequently as the disease will become more extensive, that is when it might become symmetrical, and that is where you will read about this cape distribution. The next part that I want to say is the motor manifestations of this patient. For this, I want you to again go back to this diagram with me and listen to the next terms with lot of care. I will be slightly modulating the diagram to now incorporate another pathway. This pathway that I am currently showing before you in yellow color is called as corticospinal pathway. Well, corticospinal pathway is running from area 4 of the brain, going down via the internal capsule into the brainstem, and then from the brainstem into the spinal cord. It obviously crosses over into the opposite side at the lower border of the medulla. Now, when this syrinx will expand, it can definitely impinge on the corticospinal pathway as well, as I've shown in this diagram. And it is not a necessity that both corticospinal pathways may be involved. It could be both corticospinal pathways or only one of them getting involved, because of which the manifestations of spasticity and brisk deep tendon reflexes could be written in the question. In fact, the description in the question after the sensory manifestations is the main reason why we are discussing this topic, that he might say the word ipsilateral spasticity. Since the crossing over has already occurred, therefore, now since I'm talking about deficit in the spinal cord, so I'm saying the word ipsilateral spasticity, that is a separate thing, that if the disease will progress, it could be bilateral spasticity. Similarly, he might say ipsilateral brisk deep tendon reflexes, or he might actually mention regarding a Babinski sign bilaterally present. Please appreciate the fact that per se, whenever we are talking about the brain, the manifestations are occurring contralaterally, but if it's going to be spinal cord, he might deliberately write in the MCQ ipsilateral Babinski sign, and if the syrinx expands much more, and subsequently bilateral involvement could definitely occur in the person. Apart from this, I want to highlight that the characteristic feature of spinal cord lesions is that at the level of the lesion, the manifestations are always of lower motor, and below the level, there would definitely be a feature of upper motor. That's a standard feature in all spinal cord lesions. So because at the level of the lesion, like suppose the syrinx is in the cervical canal at C5, C6, so biceps will definitely suffer from lower motor, but in the legs, there is going to be spasticity. You are aware from basic sciences that whenever there's a lesion in the spinal cord, at the level of the lesion, there would be features of flaccidity and lower motor, but below there's going to be spasticity. So in this case, there might be a mention of wasting of the intrinsic muscles of the hand or wasting of the biceps per se. So wasting of hand and arm muscles can also be described in this case. I want to highlight that lots of time in this question, he might also incorporate the motor manifestations, because he wants to see that you are aware, obviously painless burn in the hand is a feature of syringomelia. So he'll try to mix up the motor manifestations as well to throw you off the track. But as you are intelligent chaps, you obviously will not get distracted by what the examiner is trying here. And you will now comment on the investigation of choice in this condition, that would be MRI spine. Once the MRI spine has confirmed that there is a syrinx present and it is causing these manifestations by pressing on the tracts, you see, you can't predict the progression of the syrinx. It can expand horizontally, it can expand vertically also. The management of this condition will be surgical decompression. The surgical decompression is different from the decompressive surgery that we talk about in prolapsed intervertebral disc. In this particular case, a spine surgeon will definitely take care of ensuring that the subsequent tracts are not impacted. Lots of time patients might actually refuse surgery because patient is not having any pain. You see, patient is trying to be smart. He says, sir, if I had pain, I would have got an operation done. If I don't have pain, let it be. If he does not get surgery done, then the manifestation developing in this guy can be syringobulbia. You see, the syrinx can expand vertically also, and it can actually impinge or involve the brainstem. Therefore, the bad news is that now the ninth, 10th, and the 12th nerves also get involved in this individual, and because of the ninth nerve involvement, there could be nasal regurgitation of fluids. 10th nerve involvement, speaking will become a problem, aspiration risk will increase. So, therefore, the same patient who was earlier refusing surgery to you, now he cannot speak, he will not be able to drink, he will not be able to eat. I mean, those activities that we don't even bother about, this guy will not be able to do these activities. So syringomelia, guys, can be a complication of untreated syringomelia. Like this guy had refused surgery, so that is why this complication can develop. However, this is going to develop in the later part or later phase of the illness. Now, since I explained to you that this occurs because of Arnold-Chiari malformation type 1, it is my job to next explain to you that what do I mean by the word Arnold-Chiari malformation type 2. Please remember, there are 4 types of Arnold-Chiari malformations. Type 3 and type 4 are not compatible with life. We can take this to be representation of the lateral ventricles of the brain. This can be taken as the third ventricle. Then is going to be the fourth ventricle. Then I have shown exit foramina in this case. The lateral ones would be referred to as Luschka, and the medial ones would be called as Magendie. You see, the cerebrospinal fluid, which is produced at a rate of 20 ml per hour, would be produced by the choroid plexus. It's going to travel in this fashion, exit out from Luschka Magendie, and is going to accumulate in the basal cisterns. Then from basal cisterns, it would be funneled into the subarachnoid space, and the rate of production of CSF and the rate of reabsorption of CSF is the same. I will now be introducing cerebellum in this case. The red that I'm showing here is the representation of the cerebellum. What happens in Arnold-Chiari malformation type 2 is that there is an inferior displacement of the tonsils of the cerebellum. In fact, leave a line in between after Arnold-Chiari malformation if you're noting this information while I'm speaking. The message is there is an inferior displacement of the cerebellar tonsils. Now, what is the impact? The impact is that it will press on the fourth ventricle, it will compress the fourth ventricle, and if the fourth ventricle is squeezed, then the proximal system, that is going to be the third ventricle and the lateral ventricles, will begin to dilate, and you would be having is a manifestation of congenital hydrocephalus. The reason why Arnold-Chiari malformation type 2 is asked to you is primarily because of 2 aspects. One, because the fourth ventricle in this condition is compressed by the inferior displacement of the cerebellar tonsils. So there could be a question simply saying small posterior fossa is a feature of, your answer would be the topic that we are studying. And second, Arnold-Chiari malformation is not a neural tube defect but can be associated with neural tube defect. In fact, this is the reason why I'm discussing it, guys. It is not a neural tube defect. It can be associated with a neural tube defect, and this association with neural tube defect would be with myelomeningocele, where a baby will be born with a malformation in his back from where the spinal cord tissue might be visible. In fact, there might be a sac that might rupture from where the CSF will leak, and you can see the nerve roots, you can see the spinal cord, and the child will die because of meningitis. Arnold-Chiari malformation can be associated with myelomeningocele is one of the reasons I want you to remember. The second point to be remembered is small posterior fossa. Now I will mention our counterpart MCQ. Large posterior fossa is a feature of. Then this is another congenital malformation called as Dandy-Walker syndrome. I can draw a diagram for that also, but it will not increase your strike rate in the MCQ because the core issue is right here before you, small versus large posterior fossa. And yes, the implication for the case would be congenital hydrocephalus. You are aware of the fact that one of the leading causes of congenital hydrocephalus is aqueductal stenosis, right? Then can be torch group of infections, but these some important aspects that I've highlighted for Arnold-Chiari malformation are worth remembering. You have today studied that Arnold-Chiari malformation type 1 associated with syringomelia. Arnold-Chiari malformation type 2 is associated with myelomeningocele. So those are kind of aspects that he will expect you to remember. I shall now be explaining 2 more diseases of the spinal cord to you, that is Conus Medullary syndrome and then chordae equina. I'll mention some baseline information first. You're aware that the length of the spinal cord is 45 centimeter. Subarachnoid space would end at S2 level, that you are aware from anatomy, whereas spinal cord ends at L1 when it comes to adults and it ends at L3 when it comes to children. So spinal cord is one organ that is actually going up. You know, it's increasing in length obviously, but the level is going up when we tend to grow. I repeat that again. He has asked regarding subarachnoid space ends at, the answer is S2. But if he talks about spinal cord and he says that that would be ending at then your answer would be L1 for adults and L3 for newborn babies. Now this terminal part of the spinal cord that I mentioned before you and I'm shading at the moment is called as Conus Medullaris. And then I've shown some nerve roots which are coming out of this area. I've shown some more nerve roots also. I've shown for clarity in the diagram only on one side. The nerve roots that I've shown in color blue, their root values are L1 to L5. Whereas the nerve roots that have been shown in color red are having root value of S1 to S5. Now let us imagine a patient is having carcinoma prostate, which is one of the common cancers in males, and the cancer has metastasized to this area, that is conus medullaris. The topic that I will explain to you now would be called as Conus Medullary syndrome, and one of the reasons why these patients come to you is bladder and bowel complaints. The yellow spots can be taken as metastasis, which can easily come from carcinoma prostate via the Bateson plexus. You can see that when it comes to Conus medullaris, then mainly it is S1 to S5. The area in red is S1 to S5. The area that I've shown the nerve roots in blue is L1 to L5. But in Conus medullaris, the area that is damaged is mainly S1 to S5. I will now be evaluating the knee jerk of the patient. KJ means knee jerk. AJ would mean ankle jerk of the patient. I will also be doing a sensory examination in the perineal area of the patient. And lastly, I will check for whether bladder complaints and bowel complaints are being told by the patient or not. So let us see what's going to be the result. You are aware that the root value of the knee jerk is L2, L3, L4, but in this case the damage is not at L2, L3, L4, the damage is at S1 to S5, so therefore knee jerk of the patient will definitely be normal, it will be preserved because the damage is occurring at a different area. However, the root value of the ankle jerk is S1, S2, and in this case the ankle jerk in the patient will be lost primarily because there is a local damage at the root values that I've highlighted. The sensation of the perineum is same as the innervation of the bladder and the rectum, that is S2, S3, S4. So since the damage is occurring per se in S1 to S5, so therefore when I do a sensory examination of this patient, I will encounter saddle anesthesia. The fourth manifestation of this person will be related to the urinary bladder. You see, in this person, I have explained that awareness of when there's approximately 50 ml of urine in the bladder, that comes at a particular amount, about 50, and then when the amount increases to 150 ml, that is when urge will come. But if there's damage to the nerve roots, that is S2, S3, S4, then neither the awareness will be there, neither the urge will be there, so person will not feel like urinating for the whole day. Whole day has gone by, the bladder is bursting with urine, the bladder is full of urine, there might be 500 ml of urine, but there would be no pain, no discomfort, no feeling of going to the washroom, and now this bladder is stretched to the brim, so it will contract in one go, and maybe out of 500 ml, 300, 400 ml urine will pass out without any warning. This kind of manifestation where large volume of urine might be passed without warning is called as overflow incontinence, and lots of time in MCQs instead of using this term overflow incontinence, he might even use the word autonomous bladder. This bladder, I would say, is not behaving like it should normally. You see, in a normal person, when urge comes, person will try to go to the washroom, urinate and come back and do his her job. If somebody is busy, like a doctor is performing surgery, he can hold his bladder for some duration. Once it's done, he can use the washroom access. But in this case, the person will not feel anything. There will be no sensation of going to the bathroom in this person since S2, S3, S4 is hampered. So that is why I use the word overflow incontinence / autonomous bladder. Remember, automatic bladder is when the lesion is above the level of S2, S3, S4. But in this case, primarily the metastasis has destroyed the nerve roots which are innervating the bladder. So Conus medullary syndrome is going to have the following profile, and an MRI spine will definitely tell you about the damage. Now, let me slightly change the perspective. So listen to my next words very, very carefully. Suppose a person is having damage to these nerve roots. If the damage is occurring to these nerve roots, now obviously the nerve roots are present bilaterally, so they could be bilateral damage, it could be unilateral. But the term that I'm using now is called as cauda equina syndrome. Let us see what's going to happen in this patient. I am going to check the knee jerk, ankle jerk, perineal sensation in this person. I'm going to check out the status of the bladder and the bowel in this case. Let's see what is the final interpretation. Since in this person L1 to L5 is smashed, you see chordic vena means the way I've shaded in black, L1 to L5, S1 to S5 is smashed. So knee jerk, which has a root value of L2, L3, 4 will be absent. And even the ankle jerk in the patient will be absent. And because of the perineal sensation gone, saddle anesthesia would once again come up. In fact, before I write further things in this discussion, I hope you were able to pick up the main differentiating feature. Though MRI spine can help you in differentiating, what is the clinical difference? The clinical difference is that knee jerk is preserved in conus medullaris. Why? Because damage is in S2, S3, S4 or S1 to S5, and the knee jerk levels is much higher, that is L2, L3, L4. You can appreciate the main difference. You see, the main crux of explaining this topic to you is this final statement that I'm highlighting. I mean, this was the main question, that which is one clinical finding that helps you differentiate between conus medullaris and chordic vena syndrome. In fact, in chordic vena syndrome, guys, damage may not be bilateral, it can be unilateral. So they might be one-sided knee jerk also absent. The other manifestations in these patients will remain the same. Both patients would be having saddle anesthesia. Both patients would be having a development of overflow incontinence. It is mainly for this slight fundamental difference that I wanted to highlight this. So that you remember this on a long-term basis, I'll make you practice this again. Chorda equina syndrome versus conus medullaris. Usually, conus medullaris syndrome is due to meds, and chorda equina syndrome is primarily because of trauma. Conus medullary syndrome per se, when it comes to MCQ perspective, if he says what is the presenting complaint, the presenting complaint is the patient is not able to feel his bladder and suddenly large amount of urine is passing without any warning, that is overflow incontinence. In chorda equina syndrome, however, the presenting complaint is that of radicular pain. It's a radiating pain that is developing in this chap. On clinical grounds, knee jerk will always be preserved in conus medullaris, whereas knee jerk will always be absent in chorda equina syndrome. The logic is that in conus medullaris, the damage is much inferior. It is S1 to S5 that is hampered, not the lumbar roots. Whereas in chorda equina, it is a combination of both the lumbar as well as the sacral nerve roots getting impacted. So this is a slight difference that I want you to pick up, though obviously imaging will help you in identifying the differences in this case. I also want you to remember that in the previous lectures I've highlighted regarding Guillain-Barré syndrome or transverse myelitis, where I've talked about again spinal cord involvement, and I've highlighted that these patients would be having features of lower motor neuron lesion. Please appreciate the fact that whenever you read about the term spinal shock, you see lots of time this term might be written spinal shock, then initial manifestations of spinal shock will be that a lower motor neuron manifestation. Like for example, a construction worker was working at a height of 20 feet and he was not using the safety cable and it was raining also. So he might give you a case like this: construction worker fell from a height. Luckily, he did not fall on his head. He did not smash his pelvis. He fell flat on his back and his spine got fractured. Please remember, whenever there's going to be spinal shock initially, then the initial presentation in spinal shock is going to be that of lower motor neuron lesion, at least for the first week of illness. You see, in the first week of the illness, it's going to be manifestations of lower motor neuron lesion that would be occurring in the patient. Why I've highlighted that is that in transverse myelitis, I was talking about a particular sensory level. So the usual query of most doctors is that if you're talking about a sensory level, then at the level of lesion, it should be lower motor. Below that, upper motor manifestations should come. Yes, they will come, but after 1 week. The initial presentation of transverse myelitis is that of a spinal shock. So overall lower motor manifestations in the form of a flaccid paraplegia will be present. I reiterate that statement. GBS is lower motor, no issues. Nobody has a problem with that. Transverse myelitis will also be having initial presentations of lower motor only. And after 7 days, gradually the reflexes will start appearing. Like you are aware from especially the physiology component, that one of the reflexes that can come back in spinal shock, in fact, one of the first reflexes that can come back in patient of spinal shock can be bulbocavernous reflex, and then subsequently withdrawal reflex. So then subsequently the manifestation will appear that at the level of the lesion, like suppose he has fractured his cervical cord, then at the level of the lesion there would be features of lower motor neuron lesion, like the biceps of this guy will be flaccid, the biceps jerk of this patient will be absent, whereas below the level, that is in the legs of the patient, the same construction worker who had fallen from a height, last week his legs were flaccid, But now the legs of this guy will be exhibiting a spasticity with brisk deep tendon reflexes. So spinal cord behaves in a slightly different fashion when it comes to at level and below the level. The reason for that being corticospinal tract involvement. And corticospinal pathway, wherever it is involved, it will always contribute to spasticity manifestations, even if the lesion is in the spinal cord. I mainly want you to be sensitized to the fact that spasticity can be written even in a question of syringomelia. The query most doctors is, sir, it is a spinal cord lesion. How spasticity? The spasticity is corticospinal path involvement, and the same thing can happen even in patients who are having spinal shock during the recovery phase. I have tried to, in this particular topic, explain to you certain very critical aspects which are asked for spinal cord diseases. It's always a good idea to go through this lecture to get a better overview of most of the aspects which I have discussed here, which would definitely help you in increasing your strike rate in the final exams. So keep hammering, guys. Keep learning new facts and come up with great results. Thank you so much for hearing.